I wish to express my gratitude to the organizing committee for the opportunity to be part of this magnificent event. I am Luis Miguel Duchén Rodriguez, neurosurgeon from La Paz, Bolivia, South America. Today, I will show the functional result, the administration of ozone and PRP as treatment for low back pain in lumbar disc herniation. I don't have conflict of interest. Low back pain is a disorder with a significant impact of the clinical status of patient with socioeconomic and public health consequences. Intradiscal administration of mixed ozone and PRP is a minimal invasive and low risk alternative for the treatment of pain caused by herniated disc. The objective of this work is to determine the functional result, the administration of ozone and PRP in patients with low back pain and low back pain with radicular irradiation secondary to lumbar disc herniation. Patients were enrolled prospectively and single study site from January 2016 to March 2020 and the Center for Neurological Diseases, La Paz, Bolivia, in observational cohort study. There were 55 patients consisting of 24 females and 31 males with an average age of 48.6 and average follow-up to 25.8 months. The inclusion criteria were document diagnosis of acquired symptomatic lumbar herniated disc, acute low back pain at less for 6 weeks month with BAS greater than 5, 6 weeks of fairly conservative treatment, age 18 to 75 years old, BMI under 40, a dermatomal distribution of pain consistent with advanced radiographic imaging findings, a minimum retained disc height of at least 50 of adjacent disc level, MRI signal intensity of the herniated disc equal or greater and the rest of the nuclear purpose of T2 waiting sequence. The exclusion criteria were comorbid conditions affecting disc health, such as metabolic disease, infection, trauma, spondylolisthesis, radiculopathy of claudication symptoms from bony foraminal, lateral, or central canal stenosis, herniation involving non-contiguous disc fragment or herniation extended past the facet joint, tumors, impairment of bladder or bowel function, motor strength deficit in the lower extremity, a recent epidural steroid injection in the past 2 weeks, previous spinal surgery including discectomy, arthroplasty, or fusion at any lumbar level, symptomatic sarcoidotic joint disease, pregnancy or female patient wishing to become pregnant during the study, fibromyalgia, more than 3 months sick leave, no drug or alcohol abuse, diagnosis psychiatric disease of psychological distress. The gas mixture is created by oxygen ozone generator system. Oxygen was converted in ozone directly. The oxygen ozone was prepared at a standardized concentration of 40 micrograms ml. A total of 300 cc's of peripheral venous blood was drawn under sterile technique. It was feed centrifuged at 3000 RPM for 8 minutes. The PRP was obtained in a laminar flow hood and was activated with ozone concentration of 80 micrograms ml. In the operating room, the administration of ozone and PRP is performed under sedation and local anesthesia with fluoroscopic guidance. A 20 French chival needle is introduced in the intervertebral disc through the oblique transforaminal approach for the intradiscal injection under conscious sedation and local anesthesia with 2% lidocaine. Approximately 345 ml of the oxygen ozone mixture at concentration of 40 micrograms ml was injected, followed by 3 cc's of the activated PRP. The intraarticular facet injection were in the prone position. A 22G spinal needle, spinocam, was introduced in the subapophyseal joint and injecting 2 ml of oxygen ozone PRP mixture. The exact amount was injected through the sacroiliatus and transforaminal into the neuroforamina in the symptomatic level. Patients were monitoring any adverse event for 1 hour after the interventional procedure. Typically, they were sent to home with acetaminophen 500 milligrams every 8 hours. For 24 hours, patients were clinically evaluated at 3, 6, 12, and 24 months post-treatment. Patient outcomes questionnaire included the Visual Analog Score, VAS, for low back pain, the Osbesity Stability Index for overall function, and modified Magnat criteria. There were no adverse events, infection, or any other complication. 22% of patients presented with isolated axial low back pain. The remaining 78% of patients presented with a combination of sciatica type, low back, and radicular leg pain, matching the dermatoma distribution suggested of the procedure MRI scan. The frequency of theater lumbar levels was as follows: L4, L5, 7%, L5 is 1, 18%, L4, L5, and L5 is 1, 51%, more than 2 levels, 24%. The VAS score reduced from average the 7.98 before the procedure to 2.72 after the first week. The rapid and statistically significant reduction of sciatica type back and leg pain noted with 1 week for the intervention was maintained throughout the post-procedure follow-up to 96 weeks without an statistically significant change in pain resolution throughout the entire study period. Dramatic functional improvements were reported for our patients with an early 68.3 of ODA reduction, 42.36 points, materializing within 1 week after the injection. Additionally, functional improvements were reported up until 96 weeks without any statistically significant difference between the respective follow-up. Postoperatively, excellent Magnat outcomes were reported by 36.4% of patients, good for 49.1%, bad by 9.1%, and poor by 5.4%. Thus, 85.5% of patients reported favorable results. The post-procedure MRI scans were available in 10 of 55 study patients in 4 and 12 weeks post-intervention. In this imaging, we observed the evolution of two herniated discs after the administration of ozone and PRP. The imaging showed that non-extruded portion of the disc doesn't degrade after the procedure, and even as slick increase the height after 12 weeks. Axial imaging show reduction of extruded discs and reduction of rod compression. Structural change from MRI scan lagged behind symptom resolution. Structural change from MRI scan lag behind symptom resolution, which occurred much sooner in most patients within 1 week after the procedure. Currently, there is a lot of literature of variable quality that supports the use of ozone and PRP for pain to herniated discs. We will review the most significant. Ozone has effect on inflammatory cascade, interrupting the breakdown of arachidonic acid to inflammatory prostaglandins, leading to decrease the pain, inhibits the synthesis and release of pro-inflammatory cytokines such as prostaglandin L2 and bradykinin. It stimulates the release anti-inflammatory cytokines, generates hyperoxygenation, deriving reduced pain by direct and indirect mechanisms, increasing tissue oxygenation and 2,3 the phosphoglycerate within the erythrocyte. Theoretically, it will achieve breakdown of glucosaminoglycans while reduced ability to hold water, which the turn leads to significant drop in intradiscal pressure. Nerve relief, in our opinion, this dilatation only occurs in the extruded discs. The non-extruded disc maintains its hydration as shown in this MRI. Ozone will also proceed with stimulation of fibroblastic activity with allo repair process by stimulating collagen production. On the other hand, PRP is autologous blood concentrate that can release abundant particles contain high concentration and proliferation and differentiation, promoting growth factors. Trigger is serious change that promote tissue repair. Activated platelets releasing growth factors and adhesion molecules mediate a variety of cellular interactions, chemotaxis, cell adhesion, migration, cell differentiation, and stimulate to immunomodulatory activities. These platelet cell-cell interaction contribute the angiogenesis and inflammatory activity, ultimately to stimulate tissue repair process. Illustration on the multified 5HT response follows inflammatory PRP platelet activation. After platelet activation, platelet release The granules including the 5-AT from dense granules, inciting a wide range of differential effects and various immune, endothelium, and smooth muscle cells. Activated palate release anti-inflammatory mediators. They are proficient in inducing pain but can also reduce the inflammation and pain. The injection of PRP is effective to chasing extracellular matrix accumulation, returning a high Dix hate index, increasing the T2 signal intensity, and slowing the process and possibility reversing the effects of intraocular Dix degeneration. PRP is anti-apoptotic, cell proliferation, anti-inflammatory effects, and increase the synthesis of collagen and glucans that manage to maintain the adequate water content that restores the elasticity in the head and the disc. Interventional treatments of lumbar herniated disc causing acute pain syndromes are usually limited to epidural steroid injection. An array of percutaneous procedures ranging from radiofrequency or no visualization removal or herniated disc tissue exists, with few clinical studies consequently demonstrating benefit. However, high-grade clinical evidence from double-blinded prospective randomized clinical trials supporting some regenerative anti-inflammatory. However, high-grade clinical evidence for double-blinded prospective randomized clinical trials supporting some regenerative anti-inflammatory strategies. This New York study conducted a prospective randomized controlled double-blind study with inclusion and exclusion criteria similar to ours. They found evident improvement in functional results after the administration PRP versus contrast alone. This Eurasian randomized double-blinded controlled study comparing PRP and corticosteroids for the management of degenerative spinal pain showed the superiority of PRP. This meta-analysis showed the effectiveness the intradiscal PRP of the management of ischemic low back pain. A previous meta-analysis of the latest clinical evidence suggests the high-grade clinical evidence does not support functional improvements with PRP alone. Additional studies of various PRP preparations in combination with other drugs or agents have been proposed to define further of the role of spinal PRP injection and interventional spine care. The Spine Journal published a multicenter pilot prospective randomized controlled trial conducted at 3 European hospital spine centers comparing ozone administration with microdiscectomy, identified that there are no significant difference between the functional results obtained with microdiscectomy and intradiscal ozone administration. This British journal shows functional results similar of those obtained by us. I must emphasize that ozone was administered not only in the disc, but also in facet joints and paraganglionic and paravertebral level. Our prospective observational cohort study provided convincing evidence that the spinal injection with ozone and activated PRP, including those into the painful interventional discs, can significantly improve patients' functioning and reduce the pain in most of our study patients. Spine pain following acute herniated disc is complex and may not be limited to the herniated disc alone. For this reason, we combined the intradiscal ozone and active PRP, whether the pain relief combined can form the intradiscal injection or some of the other concomitantly performing injection into the facet joints circulatus of the foraminal injection is a little consequence of our patient. One of the main limitations of our study, it cannot be determined with certainty which component of our protocol produce the most significant benefit of our patient. The substantial reduction in pain and improvement of patient function within the 1 week forever supports the feasibility concept of our ozone and activate PRP protocol. The further study is needed to validate our findings by large prospective double-blinded double-arm randomized controlled trials to diminish bias and overcome heterogeneity in outcome measures. Our prospective observational cohort study showed rapid pain reduction and functional gains in patients with acute lumbar herniated discs after spinal injected with ozone and PRP. The addition of oxygen ozone to PRP showed additional functional improvements, presumably due to the ozone-induced shrinkage of the herniated discs, the other foraminal and transforaminal injection, and the sacral hiatus, likely, presumably due to the ozone-induced shrinkage of the herniated discs, the other foraminal and transforaminal injections, and the sacral hiatus likely contributed to the additional pain relief. Further detail, ideally, double-blinded randomized investigation into clinical protocols with varying doses of ozone and activate PRP are necessary to reduce bias and more clearly define clinical useful interventional spine pain management protocols involving the ozone and PRP. This experience is published in this paper, Our Life in the Journal of Regenerative Medicine.